So we're going to be talking about some of the antiarrhythmic drugs that you're most commonly going to be using in cardiac patients. First are your sodium channel blockers. Now there's actually three different groups of the sodium channel blockers. This is your class 1 antiarrhythmics. So you have class 1A, class 1B, and class 1C. It's very important overall to know the effects that these antiarrhythmics have on an EKG. So as you can see here, class 1A antiarrhythmics can actually prolong your QRS and QT segments, whereas class 1B antiarrhythmics can actually decrease your QT. Class 1C can really increase your QRS. Your class 1A antiarrhythmics include quinidine, procainamide, and disopyramide. And these are generally used when you have atrial and ventricular arrhythmias, particularly things like ectopic supraventricular tachycardia or reentrant ventricular tachycardia. The mechanism of action is that they increase your action potential duration, which in essence increases your refractory period and your ventricular action potential. Now, it's important to note that these class 1A antiarrhythmics can actually have some toxic effects. So it can induce a lupus-like syndrome, particularly with procainamide, or you can get heart failure with disopyramide. You can also get thrombocytopenia and torsades, as well as synchronism, which gives you the symptoms of a headache, tinnitus, and you'll typically see that with quinidine. Your class 1B antiarrhythmics include lidocaine and mexiltine. And these work, again, by decreasing your action potential duration, but they particularly affect ischemic areas or depolarized Purkinje fiber areas. Now, these are typically used when you have an acute ventricular arrhythmia, such as post-MI, or an arrhythmia that is due to digitalis. They can be toxic in the sense that they can either produce CNS stimulation or CNS depression. Your class 1C antiarrhythmics include flecainide and propafenone. These work by prolonging your ERP in the AV node and accessory bypass tract without affecting the Purkinje or ventricular fiber, ventricular tissue. And it actually has very little effect on your action potential duration. These are typically used when you have supraventricular tachycardias, such as AFib, and they're really only a last resort if you have refractory ventricular tachycardia, again, because they generally have no effect on your ventricular tissue. They can be toxic in the sense that they can produce arrhythmias, especially in a patient who is post-MI, and for that reason, these class 1C antiarrhythmics are actually contraindicated in individuals who've had an MI. Your class 2 beta blockers, your class 2 antiarrhythmics are your beta blockers. These are metoprolol, propranolol, esmolol, atenolol, timolol, and carvedilol. Now, these are typically used in supraventricular tachycardia. You also might see them used when you're trying to control ventricular rate for irregular rhythms like AFib or aflutter. They work by decreasing the SA and AV node activity, and they can be very toxic in high doses in the sense that they can cause impotence, COPD exacerbations in patients who have COPD. They can cause bradycardia, an AV block, or heart failure, and severe sedation. It's also good to be wary of using these in diabetic patients, as they may mask hypoglycemia. Your class 3 antiarrhythmics include your potassium channel blockers. These are amiodarone, ibutylide, dofetilide, and sotalol. These work by increasing your action potential duration. They can also increase your ERP, and it's important to note that these can increase your QT intervals, as I mentioned before. We want to know how these antiarrhythmics certainly affect our EKG rhythms. They're typically used in atrial fibrillation or atrial flutter or ventricular tachycardia, particularly amiodarone or sotalol. Sotalol and ibutylide can cause torsades de pointes, so be wary of that. Amiodarone can have problems in individuals with pulmonary fibrosis, or it can cause hepatotoxicity, hypothyroidism, or hyperthyroidism issues, and it can cause skin deposits as well. You may also see neuro side effects as well as constipation, bradycardia with these class 3 antiarrhythmics. Your class 4 antiarrhythmics include your calcium channel blockers, that is the non-dihydropyridines, verapamil and diltiazem. These work by decreasing the conduction velocity and increasing your ERP, as well as increasing the PR interval on an EKG, so be sure to look out for that. They typically are used in rhythms that are nodal arrhythmias, so like supraventricular tachycardia, or for rate control and in atrial fibrillation. Their side effects include things like constipation, flushing, swelling, heart failure. It can cause an AV block or sinus node depression, and it also can cause gingival hyperplasia. Some of the other antiarrhythmics that you should be aware of include adenosine and magnesium. Adenosine works by increasing the potassium that is outside the cells, essentially hyperpolarizing the cell, therefore decreasing the calcium effects. The drug of choice for abolishing a supraventricular tachycardia is in fact adenosine. It's important to note that this has actually a very short acting effect, typically around 15 seconds. Be wary of some of the side effects, which include flushing, hypotension, chest pain, a sense of impending doom, as well as bronchospasm. Magnesium is particularly effective when you're dealing with trisazinate points or digoxin toxicity. So that concludes our coverage of antiarrhythmics.